So I'm very happy to introduce our speakers today. So it's Dr. Gilani and Katie Mills for an update on management of cancer-associated thrombosis. Many of you will know Dr. Gilani, who's working as a specialist doctor in clinical oncology at this trust. He's previously worked in Bristol Haematology and Oncology Centre as well as internationally. He has certification in oncology and radiotherapy. He's developed a special interest in anticoagulation and cancer-related venothromboembolism and presented a few months ago also. He's joined the UHNM STAC team, so that's the Staffordshire Thrombosis and Anticoagulation Service, in May 2022 to help set up this new cancer-associated thrombosis service. Katie's joined the UHNM anticoagulation team in 2015 as a CNS and has further developed into the nurse practitioner role in 2018 under the STAC team. She's further developed into an ACP role this year to help also facilitate the new cancer-associated thrombosis service. So welcome, Shahid and Katie.
Thank you very much for your kind introduction, Mr. Ismail. My name is Dr. Gilani, and I'm thankful to you all be here and giving me an opportunity to talk about cancer-associated thrombosis. This has been an issue for quite some time now, because we know that cancer patients have almost fourfold chance of getting thrombosis when they are diagnosed or when they are on chemotherapy. Especially when they are on chemotherapy, their chances of thrombosis go to 24%. So it's quite increased chance of getting thrombosis. And also they have increased risk of bleeding. So whenever there is a cancer, we give them chemotherapy. So when I talk to say chemotherapy, it means systemic anti-cancer therapy, because now we have immunotherapy, we have target therapy, we have whatnot, VEGF blockers, we have epithelial blockers. So it's lots of drugs. So all of these drugs are classed as now systemic anti-cancer therapy. So SACT, I will call it. So whenever they have SACT, so they can get some side effects which may actually put them at increased risk of bleeding on its own. So the cancer itself can cause new vascularization, which means new blood vessels are formed first, and around it new cells are created. So these blood vessels are very much prone to get bleeding. And the cancer cells always secrete a lot of cytokines, a lot of procoagulants, we call them. They just go into the circulation and cause trigger the cascades, which we call it clotting cascades. You may have heard in the basic sense of intrinsic mechanism and extrinsic mechanism. So that's why they are, and also there are vascular issues because their endothelium are inflamed. So these are triggered, and also the patients itself. So there's cancer related problems, patient related problems, and also the vascular related problem, which can actually trigger them to form clots. So all of these actually put them. So this is the I just because I was giving you the introduction, because if you want to listen my previous talks, because there's a series of CAT introduction which I have done in 2021, two lectures in 2020 and in 2019 as well. So we know that low molecular weight heparin was standard of care for last many years after the clot study in cancer patients. Today we are talking only cancer patients with thrombosis. So this remained standard of care last 15 years, because that plot study was comparing between low molecular heparin and warfarin. Warfarin was standard of care at that time. So the low molecular heparin became standard of care because it was having less bleeding and less incidence of recurrent thrombosis. So we were very comfortable for last 15 years, no problem. But last about 2 to 3 years, new anticoagulant drugs have come up, which are direct drug thrombin inhibitor like dabigatran, or maybe factor X inhibitors, which are rivaroxaban, edoxaban, and apixaban, which are recently had randomized clinical trials, and they were found comparable with low molecular heparin. And this was the meta-analysis which was just published early this year, and it has shown. I was surprised when I heard and when I saw it. It's a direct. It says that direct anticoagulants should be standard of care for cancer patients with thrombosis. So it seems that it gives you an incentive that all cancer patients are fine with DOACS. When I went to nitty-gritty, I found it was a meta-analysis actually, so it is not a randomized a trial. So usually the guidelines and the guide for any drug comes from a randomized clinical trial comparing with the standard of care. So standard of care is low molecular heparin. So then I saw another one, which was actually using direct anticoagulation, coagulant drugs uh, that they have lower incidence in hemorrhage in patients with brain cancer. So we call it glioblastoma. So basically, we were excluding these patients from randomized controlled trials. So no brain, only few were actually included, which were already cured and our surgery has done. So the randomized controlled trials are very selective when they select the data, when they select the patients. So this was a retrospective. When I went into it, it was a retrospective study done in one of the US hospitals, and it has shown that the incidence was actually less when they given DOAC as compared to low molecular heparin in brain glioblastoma. So this was quite encouraging. So that also pursue us that, okay, DOACs are safe, so let's start it. Um, and we found that these are not that simple actually, because when when we go into nitty gritty of these one, which I have already mentioned, that there are unmet needs. So this was published by me in 2019-20, when we said, okay, there is a urgent need of looking at how we can actually manage these patients properly, where should be a dedicated clinic or service. So at that time, there was few already started in the world, especially in Wales, one in London, one in US. So there was an example. So one publication from Professor Simon was published, outcome of dedicated Cancer Associated Clinic and Service, and he has published quite positive data with that. But there are unmet needs already, because we know that the guidelines are all based on the results of those randomized clinical trials, where the selection of patients were actually very specific. So, for example, in many of the trials, they have selected not beyond 70 years old, or they have not selected some of the brain mets, and they have not selected thrombosis with central line thrombosis, and similarly some planktonic or splenic thrombosis were not selected, inferior vena cavas, or those patients who had thrombolysis therapy, or those patients who had sinuses of the brain, thrombosis of the sinuses of the brain, they were not selected. So the data from randomized controlled trials are very selective, and we should take it with a pinch of salt. I will discuss it in detail. So the next, uh, so recently these were basically new. Uh, so what is the result of these? There are four randomized clinical trials which we will discuss very briefly today. One was a pure UK trial, which compared low molecular heparin with the rivaroxaban Select D trial, which was a West Midland trial, but it included all the people from the UK. The other one was comparing low molecular heparin with the edoxaban Hakusai VTE trial. The third one was small trial with the apixaban, domoglurate, heparin, Adam VTE trial. The fourth one was slightly bigger, more than 1,000 patients. It was CARAVAGGIO trial that was quite big, comparing low molecular heparin with the apixaban. So we have these 4 trials, which has led to a number of guidelines. Are you seeing my slides?
Yes, we can see your slides, Shahid.
Okay. So, what are the recent emerged therapeutic options have actually? So, what is the problem with them? So, the problem is a fear of increased risk of bleeding with them. This is a fear when it comes to a doctor or a clinician to choose between low molecular heparin and DOAC, and the organ compromisation, because a lot of people have a low liver functions, and their renal functions are compromised as well. They are on chemotherapy, and also their body weight fluctuates, and their oral intake is not very good actually, because their GI tract have, like for example, side effects from the chemotherapy. They have diarrhea, they have vomiting. It's quite common, so they can't keep anything in. So these are real issues with the oral anticoagulation, and these are unmet needs as well. So if you say that they are on NG tube, so obviously that also, and the packed feeding, because that it actually bypasses the stomach. Some drugs like rivaroxaban need stomach mucosa to get absorption. So similarly, there is the good things as well, because we don't need to monitor it. Patients love it actually; they like it because injections. Nobody like injections actually. So majority of our patients like oral anticoagulation. So also we have noticed that during the chemotherapy, the platelets go down, in the middle of the cycle, and then they come up. So the fluctuation of the platelet also give us a challenge, how to modify or reduce the amount of anticoagulation, like oral coagulation. And also that was the reasons the dedicated clinic service idea came up, and then we have implemented it here in University of North Midlands and Cancer Center with the STAC team, and we'll go through it. And Katie is there to talk about it at the end. And these are the trials which I have just mentioned to you. On the right-hand side is the trials which are just mentioned. These are 4 randomized clinical trials which are comparing DOACS with low molecular weight directly in cancer patients. On the right side is a preventive. We are not talking about prevention today, because that's a total different ball game. We have talked about it in 2022 January. So recording is there in the library. If you want to listen, you can actually. And so these are quite good. Mr. Zhang has put all these 4 trials in one slide. So if you see here, the select D trials were only having 400 odd patients, and Hakusai is also a similar number of patients, but Adam VT is a slightly smaller number of patients, and CARAVAGGIO is the one which number of patients are quite good, actually more than 1,000 patients. So if you see they are comparing different DOACs. So the select D is comparing rivaroxaban, which is a direct 10A inhibitors, and also the other ones are edoxaban, and the Adam VT is apexaban. Adam VT is smaller one, smaller trial, but the selection criteria and the aims are slightly different between these 2 trials. The last one is CARAVAGGIO, which is a quite big trial, and it has actually shown the outcome is comparable with the low molecular heparin. If you compare the result of these trials, and if you see the outcome is the select D is the primary outcome is VTE recurrence. So the VTE recurrence is less in rivaroxaban as compared to the low molecular heparin, but bleeding risk was slightly increased. And similarly, the primary outcome for Hekosai VTE was cumulative, so they have put both together. So the bleeding and the thrombosis, bleeding risk was slightly high, and thrombosis risk was reduced as compared to low molecular heparin in edoxaban, but they have actually put it together. So when they put it together, the result was that the result is equivalent as compared to, so they said that edoxaban is non-inferior to low molecular heparin in cancer patients. So RMBT is a smaller one, smaller trial, but it has shown that apixaban is equivalent. And similarly, the CARAVAGGIO trial has shown primary outcome was VTE recurrence, and in that they have shown that VTE recurrence is less as compared to the low molecular heparin, and also the bleeding is less as compared to low molecular heparin. And they have also found that the bleeding was comparable in GI malignancies and also in epithelial malignancies like uroepithelial malignancies, for example, bladder or kidney. Because in the first trial, the SELECT trial and also the other edoxaban trial has actually shown in their sub-analysis that some of the bleedings were actually coming from those cancers where they were involving epithelium. For example, stomach cancer, intestinal cancer, and uh, bladder cancer, kidney cancer, and ureter cancer. So bleeding were more common in that. So when they have seen in sub-analysis and CARAVAGGIO that bleeding was not common, but some of the retrospective study, there was another retrospective study published in 2021, which has shown that there is some bleeding in apixaban as well. So we have to be very cautious when we are actually selecting between these direct anticoagulant drugs. Now, these were the outcome of CARAVAGGIO trial, which is specifically mentioned in a sub-analysis that the bleeding risk was comparable with low molecular heparin even in GI malignancies and even in epithelial malignancies of urogenital tracts. So that was quite positive actually, and the VTE risk is less. Recurrent VTE is less as compared to low molecular heparin Caravaggio. So this was like a setting standards with this trial. Now, what are the implication of randomized control trials? So whenever there is a randomized control trial, which is comparing to already a set standard, that gives us a new evidence to act on. And immediately we went for it actually. And oral anticoagulation was thought to be quite good. And immediately after that, guidelines started pouring out from different parts of the world. For example, European Society of Medical Oncology, American Society of Clinical Oncology, National Cancer Network, which is US 28 Cancer Center Network, is a comprehensive network, we call it. So they all have started pouring out different guidelines. For example, this was in 2019 when this evidence was just published, and International Society of Thrombosis and Hemostasis also has launched their guidelines. So if you see the guidelines in last couple of years, you will see the guidelines are published after the guidelines. So every society and every part of the world has actually started generating their guidelines. So ASCO has actually mentioned in their 2020, which was their latest guidelines, that DOAC should be considered as a first-line drug for those patients, but low molecular heparin should also be considered, and they have mentioned rivaroxaban. And similarly, if you go to the National Comprehensive Cancer Network guidelines, they have mentioned apixaban and edoxaban as comparable, but avoiding in GI malignancies because of first two trials, the SELECT-D trial and also the Hakusai trial, Hakusai VTE trial. Now, dabigatran is not used in much of cancer patients because it's a direct thrombin inhibitor, is slightly more bleeding risk. And the NICE has then issued another guideline in 2020 is saying that we should consider DOAC as a first-line drug for cancer patient for first 6 months, and long-term anticoagulation beyond 6 months for secondary prevention should also be discussed. But this is unmet need yet, so I will just mention that there are actually three phases of anticoagulation in cancer patient: first 6 months, beyond 6 months, and lifelong, which is called extended anticoagulation. So that's how we have divided into different phases. Now, American Society of Hematology, which has just published their guideline last year, which has mentioned all three. So apixaban, rivaroxaban, and low molecular heparin to be used for these patients, as all are equal in. And also they mentioned the short term. Initially, they should start with either with the DOAC or with the low molecular heparin, because different trials have started with low molecular heparin for first 7 days, and then they started on and rivaroxaban was started without initial first days of low molecular heparin. And then there also mentioned about long-term treatment with these patients. For the patient with acute cancer, long-term anticoagulation, we call it indefinite. Duration can be for 1 year, 2 year, but there's no data available actually. So they mentioned, we suggest that to prevent VTE, we should think about it, because they are very high risk, especially with uncontrolled malignancy in patients who are on chemotherapy. And now the treatment, but the treatment is not that easy actually. There are special situations we have to consider. For example, in the randomized control trial, there are no intracranial malignancies and no metastatic brain mets were included. There was one patient in SELECT-D, and there were only two patients in CARAVAGGIO. So it's a very small number. And thrombocytopenia was a problem, because in some of the trials, the cutoff value was 50,000, but in CARAVAGGIO, the cutoff value was 100. So some of the trials selected different patients at different levels. So selection criteria in these trials were quite stringent. And the renal impairment, the patients, when we see in our practical clinics, they come up with the polypharmacy, with a lot of drugs, with the renal impairment, with the liver function problems, with their all these effect of chemotherapy on their platelets. So they are quite different, and there is no patients were included in these who had pregnancy, and there was no patients with the extreme of body weight. For example, there was no patient below uh, 40, and there was no patient above 120. So obese patients are a problem for us, whether because there's no data available actually. And there was also those patients were not included who had recurrent thrombosis. For example, in the trial, if they had recurrent thrombosis, they were out of the trial, and they were not included. So obviously, those patients who had one thrombosis after another one, or extension of their clot, they were not included. So those patients who had PEG feeding, they were not included. So similarly, the catheter-associated or PICC line-associated thrombosis patients were not included. So there are some other patients which were excluded were unknown sites, for example, sinus, brain sinuses thrombosis, or spleen thrombosis, splenic vein. And arterial thrombosis are also were not included. So these are all summarized here. So these are really practical issues for us. And then the choice, when you come with the patient in front of you, they have their own agenda. So they don't want injections, and also in some parts of the world, the cost is also is a problem, really. And also the drug to drug interaction, so they are on many drugs. So some of drugs are directly competing with the glycoproteins on the surface of the cell, where they are actually absorbed. So they are competing with that chemotherapy, so their level go up and down with that. if they are competing. And also with the liver cytochrome, some of the chemotherapy are actually inhibitors, and some of the drugs are actually inducers, and some of them are on cardiac medications like diltiazem, phenytoin. They induce cytochrome enzymes, and the level of DOACS can go down. In that situation, they are prone to get thrombosis or recurrent thrombosis, and especially in some are inhibitors, for example, antifungal agents and myconazoles, and some of the other drugs are also like erythromycin, so they inhibit, so their level go up, so they tend to get bleeding. So there are also interaction with non-cancer drugs as well. So we have to be holistically looking at them. So here comes the role of pharmacist actually. So we're very vigilant in these situations. So that's the phases I was mentioning about. So initial treatment of 30 days. So we think that if you come across in an acute area, for example, A&E or somewhere where you have to start with the patient and you don't know what drugs they are on in terms of the chemotherapy and what interaction could happen. So best is to start them on low molecular heparin because that we know is the safest, and then send the patient across for people who know the best when oncologists. It was sent to the oncologists in the past, but now we have this cancer associated clinic, a dedicated clinic where you can get the opinion based on their all the history and holistically talking to the patients. And then after and we can actually either switch to DOAC or to 6 months or to continue low molecular weight heparin, because in some patients we can't actually switch due to different reasons which I have mentioned. And after 6 months we have like extended treatment beyond 6 months, which is basically unlicensed. And but we know that there is no data. There is some data available, for example, in CARAVAGGIO and some of the other trials that retrospective, but we know that patient, we have to just assess at that time what is their risk of bleeding and what is their risk of recurrent thrombosis. We have to assess them in terms of these two. If patients' malignancy is uncontrolled, so their risk of thrombosis or recurrent thrombosis remains very high, and especially with the cancer burden. So we have to assess the cancer burden as well, and also the burden of thrombosis. So if it is, for example, one single vein thrombosis and there is no much burden, so there is a chance of recurrent thrombosis is less. If the burden is very huge in pulmonary embolism and also in other areas as well, so burden of thrombosis is very high, so their chances. And also there are some patients who have like some on some drugs where they thrombogenic drugs. We have to look for it actively whether they are at increased risk of thrombosis. Now, there was a flow sheet which I published a few years ago. It is available here as well. I have put in the tables and also published, and it's available on the internet as well. You can look at it. It's very easy how to start with DOACs and whom to exclude and where to actually switch, because switching between low molecular and if once, for example, you have started DOAC, it doesn't mean that a patient is forever now for DOACs. You can actually switch. If, for example, platelet drops, you can come back to a low molecular heparin. If it is having some renal problems or liver problems, so you can immediately come back to low molecular heparin. When patient gets better, you can actually go back to DOAC. So it's an interchangeable thing. So because it's quite time consuming and intensive, and it needs proper vigilance. So that's the reason a lot of people have advocated a service, a separate service, and that's why we started working on it. And we then this is one of the few centers in the UK who had started a dedicated cancer-associated clinic for the welfare of our patients and better outcome. And so this is one of the publication impact of dedicated cancer-associated thrombosis service on the patient outcome, published by Professor Simon, and it was published in BMJ a few years ago. And after that, we know now that this clinic has a quite important role to play. And these are the unmet needs. So I will hand over to Katie, is my CNS here, and she will take over the slides from here on, and she will tell you the further what this service actually does. Thank you.
Okay, hello everybody. My name's Katie Mills. I'm the Advanced Clinical Practitioner for the STAC service and now the Cancer Associated Thrombosis service. Apologies, I don't have a camera on my PC, so you're just hearing my voice. As most of you probably know, STAC is the Staffordshire Thrombosis and Anticoagulation Centre. We were established in 2016 and we are built up of a multidisciplinary team of clinical nurse specialists, biomedical scientists with pathology staff and consultant haematologists. When we were set up, STAC did not manage deltaparin only for patients, and therefore our CAT patients were excluded from our service, as deltaparin at that time was the first line treatment for CAT. Now, with the licensing of DOACS for this group of patients, STAC have been able to join forces with our oncology colleagues to launch this CAT service. We began this service just last month, June 2022, and our lead doctors are Dr. Deepak Chandra, who is consultant haematologist, and as you just heard from Dr. Shahid Gilani. So as we all probably know, we need to take on a holistic approach for our CAT patients, and we will look towards towards national and international guidance to provide the safest, most patient-friendly treatment plans that we can. CAT patients will be discussed in a CAT MDT, or there is the option of doing that, which is held weekly in order to be able to discuss our complex patients. The CAT service also has an aim to conduct audits and to provide teaching and education to our colleagues ongoing. Okay, the CAT service will accept referrals for outpatient reviews of non-acute patients from both primary and secondary care physicians. So there is a referral criteria as listed on this slide, and so that's patients with active cancer who are diagnosed with venous thrombosis, patients diagnosed with cancer shortly following diagnosis of venous thrombosis, patients with cancer on long-term anticoagulation requiring review of anticoagulant therapy due to cancer treatments or their bleeding risks, and other referrals after discussing with the cancer thrombosis team. Okay, so this is the recently uploaded presentation which went onto the UHM intranet bulletin, and this highlights the criteria of patient that we accept and the referral pathway for these patients. Okay, so this one emphasises that we don't we don't accept referrals for non-acute patients requiring a specialist oncology haematology review. So again, non-acute patients, this will be an outpatient setting. Patients with cancer who have a suspected acute venous thrombosis need to be referred via the established DVTP pathway, and currently that's through AUC extension 71700 or the AMU and A&E when out of hours. So patients already on anticoagulation with an active cancer can be referred for an outpatient review. The referral can be found on the UHM intranet under STAC. You can email the referral over to cat.uhnm@nhs.net or contact our extension 74252, which is our office, for any further advice. Again, please do not refer any acute VT patients to the service, as the usual waiting time for an outpatient appointment will be 4 to 6 weeks. So what our CAT service will offer is a joint haematology oncology review as an outpatient. Decisions can be made regarding duration and choice of anticoagulation, monitoring of anticoagulation if that's needed, decisions regarding interactions and managing complications of anticoagulation, a follow-up by specialist anticoagulation nursing team, patient counselling and advice, a shared care with primary care where appropriate, and there's a dedicated CAT MDT to discuss complex thrombosis patients. And that's all, if anybody's got any questions for Dr. Gilani or myself.
Thank you very much, both of you, for an excellent presentation. Are there any questions at all? Arjun, do you have a question?
Yeah, I have either for Dr. Gilani or for Katie, that if I see a patient in AEC, which is obviously a cancer related thrombosis, And so do you want us to discharge this patient on low molecular weight heparin for 4 to 6 weeks and then refer it to the CAT service to see that whether he can be advised on DOACS from there, or you want us to initiate patients on DOAC provided there is no like an immediate complications due to the DOAC use?
Thank you very much. Very excellent question. Good, actually. So no, you can start DOAC from the first place if you think patient is fulfilling the criteria. There is no problem in the safety of the patient, because we have few incidences and patient was started DOAC and the low molecular heparin at the same time, saying patient, okay, start the DOAC after 1 week. You start this low molecular heparin injection first, and he actually started both together. So so it gets it like a double dose. Whenever there is a good communication with the patient and understanding the patient, whichever way you want to go for it, you can do.
Do you have any other questions? If you don't want to put your hand up, you can write something in the chat box. In the meantime, Dr. Gilani, several of the studies excluded patients with cutaneous malignancies, and one also excluded one with brain metastases.
Yes, that's right. So all of these randomized control trial have not included any cutaneous malignancies, because they are not really classed as much problematic, and the cutaneous malignancies, as you know, class into two: non-melanoma and melanoma. Melanoma is really a thrombogenic malignancy. It can cause a lot of bleeding and a lot of clots as well. That is dealt as a normal cancer, but the other one, non-melanoma cancer, also classed into two, basically. One is like a head and neck squamous cell carcinoma, where patient get a more advanced, like a stage 3 or stage 4 possibilities. So if they are uncontrolled, like a 5% of squamous cell carcinoma will be having metastasis. So those are dealt like a normal malignancy. So their chances of getting thrombosis is exactly the same, fourfolds than a normal population. But the other one, which are localized and they are controllable or curable, the chances of their thrombosis is exactly as normal population. So they are not dealt as a systemic malignancy.
Thank you very much. Any other questions? I also wanted to ask, I know there's overlap with your previous presentations with regards to prophylaxis in high-risk patients. Are you finding that you are prescribing more DOACs or low molecular weight heparin now by picking out high-risk patients?
Excellent question. I was expecting this question from the audience. I had a 1 hour and a half, like a talk, which is recorded in January 2022. So it's available in the library. So because prophylaxis is a quite different than the treatment, so that's a good theme and good idea to just prevent it before it happens. So this is what we should all do. So once things happen already, then treating is easy, so just clot has happened, you just treat it, and that's what we have talked about today. But prevention is totally different ball game, and the evidence is scarce actually at the moment. Only two, Cassini and the other one, the trial has come up with this one, but there is a significant data now that we have to calculate the risk of their thrombosis. They are not having thrombosis, so they are cancer patients. They are at risk of thrombosis. So where we have a different tools. One of the very commonly used tool is Khorana score. So if Khorana score is 3 or even 2, some people say, so it's better to start on anticoagulation. Now, NICE has mentioned in their recent guidelines that there are certain cancers, for example, um, pancreatic cancer, you should consider prophylactic anticoagulation, and some of the hematologies malignancies where they use lenalidomide and thalidomide. So these drugs are thrombogenic. So for them, they have suggested to actually give them low molecular weight heparin. So 5,000 unit twice a day, for example. So the bottom line is that we have to stratify. We cannot actually give a prophylactic to all cancer patients. Data is very, very scarce, so we don't have much information. So majority of information is from retrospective studies, actually.
Thank you very much for that. And thank you, Dr. Gilani and Katie, and congratulations on setting up this new service. And thank